Good afternoon. Thank you, Professor Rischmann. You can now present this new technology to us. Thank you.
Thank you. Well, it's a real opportunity for me to be able to share with you my experience of HIFU and more specifically a Focal One device. And I measure the honor and the privilege to be able to talk with you, to share my experience in such a wonderful meeting you have organized. So what is it about? It's about a medical need that we all have when we deal with the early stage prostate cancer treatments. Active surveillance is certainly the best indication for low-grade disease, but we know that about 30 to 40% of those patients will progress in one hand. And in the other hand, the only solution that we had before was a radical treatment, either radiation therapy or radical prostatectomy. And we have this study from Dr. Bill Axelsson in Sweden, randomized study that showed that we, above 65 years of age, we need to perform 11 radical prostatectomy to save one life. So there is a real need today of de-escalation and to fill this gap between active surveillance and radical treatments. And today we have a solution, we have an answer, which is the focal or at least the partial treatment of the prostate where the cancer is. And HIFU is certainly the best technology to address this problem because it is minimally invasive. We can do a conformal treatment and personalize the treatment to the problem, the specific problem of our patients. So I'm sure you have heard a long time ago of HIFU. This is more than emerging technology today. It's our everyday technique that we do in our practice. This is a question of a transfer of energy through a transducer to a focal point, and there you have four effects. First, a mechanical effect with the destruction of cell membranes. Second, you have a thermal effect with hyperthermia over 80 degrees. Then you have a diffusion of microbubble that creates cavitation. And last, you have intravascular microvessels coagulation that leads to necrosis, then to fibrosis. Here you have the Focal One device, and on the left, the transducer. You both have imaging ultrasound, mode B, classical mode B ultrasound, and therapeutic ultrasound, high intensity focused ultrasound. And on the two screens you have on the right, you have the possibility to manage different sources of images to create a 3D fusion using, of course, the real-time ultrasound you get, then introducing, loading the MRI, but also the zone of positive biopsies, and if needed, the PET PSA. So today we benefit with this technology of the progress of particularly the imaging technology, and probably we'll have more with AI, artificial intelligence, which is in development in this device. So just a short summary of the literature. The first important paper was signed by Hashim Ahmed and Mark Emberton in Great Britain using the Sonoblade system, and they published in the Lancet this first series of focal treatment. And you have those two figures, 90% disease control and 90% preservation of erectile function, which is, one of the main post-therapeutic problem of prostate cancer. This is the first publication. It was a small series, 41 patients, a short follow-up, 12 months. Then, several years later, we published with the French Association of Urology this study with hemiablation, which was more homogeneous, with more patients, with more centers and a longer follow-up. And the result was exactly the same that the previous paper I present you. 90% radical treatment-free survival for those patients after 2 years. And we also showed that it was possible to have a second-line therapy, even radical if needed, and even a third-line therapy in those patients. We did this paper with my friend von Velthoven. It was a comparative study of pooled data of 7 different studies with hemiablations using HIFU. And as you can see, those results are homogeneous in terms of negative biopsy rate, in terms of salvage treatment-free, and more important probably is the rate of continence, which is constant from a study to another. It's less much over 90% and preservation of erectile function over 70% in those patients. So it's a semi-live demonstration, so let's go to the OR. This is a clinical case, 60 years old healthy man, who has a PSA around 7, a T2 at the right base with 2 positive biopsy, I subdue, and as probably your patient, he wants to preserve his quality of life after treatment and mainly his sexual quality of life. So let's go to the OR. It works, I think. Yes, great. So a little description. I don't know if you see the arrow. Yes, we have it. So you have those 2 screens here. They are here. Here is the screen where we manage the image. Here we have already loaded the MRI and the region of interest. I'll come back on this. And here, after introduction of the probe through the anus and in the rectum, you have real-time ultrasound imaging. Here, the balloon of the bladder catheter. Here, the seminals, of course. And the first time, what we do, we measure the prostate that will appear here on this little screen. The apex is on the right. The base is, of course, just at the level of the bladder neck here. And then we have these 2 measures in the 2 screens. And we see that the prostate is a small one. It's 17 cc's. That is written here. Then comes the time of the management of the 3D fusion, high fusion. So we contour the prostate here, and first we mark here the 2 points to the 2 limits of the prostate, the upper limit and the lower limit, of course the apex. And once it's done, we can contour the prostate in 3 different regions and start the fusion. This is, of course, accelerated in this presentation. After about 5 minutes, maximum 10 minutes, we get this kind of image at the bottom here, where you have the prostate here and the region of interest, that is to say, the target we get from MRI, augmented with the safety margin, the oncologic margin you have to respect around the zone we want to treat it. And ECIT is to check the accuracy of the fusion, which is very good here, as you can see, so that we can proceed. Now, so do you have the apex and the base, and in yellow you have the lesion. You can either use MRI or ultrasound on this screen on the right. So now we come to prepare our treatment, and we have to define the lower limit of the treatment and the upper limits. First, the lower limits. It's very important to have a very precise definition of the apex here. And as this patient has no disease at the apex, we can spare about, I don't see it here, but it's about 7 millimeters in this lower limits, taking into account the oncologic margin. So we will be treating the upper part of the apex only. Then we define the upper limit here, which is just above the bladder neck. Sometimes you see the base of the prostate is a bit above the bladder neck, the limit of the bladder neck. And so it's now we have a coronal view of the prostate, and we define the zone that will be treated. So we have those blue points that it is easy to move in order to define the zone. And the limits you see on yellow, the yellow limit that you can see is the area inside where the temperature will go at the level we want. So what the device will be treating is inside the yellow limit and not the blue one. The blue one is in order to shape it. So of course the urethra is here. We can put some heat in the urethra, there is no problem with this. But if we have the room, like it is the case here, it is enough to treat just beneath the urethra. We should have normally to have the optimal effect, at least 2 points, 2 impacts, but most of the time we will have 3 impacts up to the anterolateral part of the peripheral zone. So we divide the treatment in different blocks, depending of course on the volume of the prostate, and each block will have between 4 or 5 slices. Now the treatment is started, and you can see that we can follow in real time the treatment, which is a little bit accelerated here because it's very repetitive. So now we have already done 2 slices. We can check the temperature. This is the rectal wall temperature, which is about 15 degrees, which is good. And before each shot, you can see here that the rectum is signaled automatically by the machine. So we have a lot of safety in terms of temperature, but also in terms of precision. As you can see here, we have a step here that if the patient moves even 2 millimeters, the machine will stop automatically. So this part of the treatment is totally robotized. We just have to look after the cavitation, for example, that appears here, the limits of the prostate. It should not be blurred, and if so, it's very easy to stop the treatment, wait for a few minutes, and start again. There is an automatic stop of the treatment after 5 or 6 slices between 2 blocks. Then the temperature can cool down. So now we are, it's difficult to see, this is probably the fourth block or the third block. You can follow the progression here. Now we are inside the supposed tumor, and we can see the region of interest here, marked in yellow, and so forth. So this will, now we have treated, it's very, very small here. You have the time somewhere. Maybe 10 minutes of treatment have passed, and the treatment lasts between 20 to 45 minutes maximum, depending, of course, both of the prostate volume and also the volume of tumor you intend to treat. Okay, so I think that would be enough for the video. Okay, so this is the image at the end. This is the MR image that we get about 3 months after treatment, and you see clearly the zone, which is now totally fibrotic in the area that has been treated. Now, this is surgery, you know. This must be done by surgeons who are used to radical prostatectomy. I've done 1,000 radical prostatectomy in my life. I've done more than 1,000 HIFU procedure. And there are technical points of importance. Very well recognition of the apex, I already told you, to respect safety, oncologic margin around the MRI target, at least 1 centimeter everywhere it's possible. And I remind you, if you have a paramedian lesion, that cancer doesn't know what the midline is, and you can have, you know, the prolongement. If the tumor is what you see in my hand, you have the fingers, which are prolongement of the disease that you cannot see on the MRI, of course. There is no problem treating the seminals, no problem with the ureters. And if you want to have an optimal energy deliverance, the best, as I told you, is to have at least 2, but better 4 points of impact inside the parenchyma. You see here the microvessel, the bundles are here, so you are not supposed to go outside the prostate, but it's perfectly possible in order to get the 3rd point, or even the 4th point, to go out of the prostate in the upper part laterally here. It's only fat and there is absolutely no danger. There are some limits, of course, and are well known. First, the rectal wall thickness. This is something that we relatively frequently have when we do a salvage HIFU. This is not the case here, but if we do salvage HIFU after failure of radiation therapy, sometimes the thickness of the rectal wall is a bit large, and it could be a danger. It should be less than 10 to 12 millimeters. Another limit is the presence of calcification that we can have after radiation therapy, for example. It could happen. And the results are less good when you have a lot of calcification. I think it's not a good indication. You may have some calcification, the peripheral or in the transitional zone, there is no problem, but it could be a limit. But the most important limit is the anterior low apex. Why? Well, you understand very well. If you have a lesion here and the sphincter is here, it might be heated here, its upper limits, and you can lose 1 or 2 millimeters of the sphincter efficacy. That could be a danger for urinary continence. So today we have about 30 years of HIFU data talking about the EDAP system. The focal one is the 3rd one after the MESIS and the Ablatherm, who was the first one with real-time ultrasound. And now we have nearly 10 years experience with the focal one. So I will talk about historical study with long-term results, which is very important. The HIFI study that we published last year and the FARP study that will be published this year. So we have a real amount of data, you see, and very long-term, 10 years, 15 years. There are 2 German studies here, 1 British study with the standard blade, and the big French study here in Lyon where the technique was created. And you see the 10 years cancer-specific survival is very high in this situation, taking into account that today we have done a lot of progress comparing with the material that we used in the early years. So probably the results should be better today. And of course, it is related to the grade of the disease, where we are nearly 100% result with low grade. But even in the high grade, you see that we can treat 2/3 of the patient with success. What about the HIFI study that we published later in European Urology? It's a bit long to give you all the details. So we compared HIFU to the standard treatment that is radical prostatectomy. More than 3,000 patients were involved in this study. And the primary endpoint was the salvage treatment-free survival. And we showed that HIFU was not inferior to radical prostatectomy at 30 months. even more, we showed that the subgroup of patients who were grade group 2 and who had radical prostatectomy had lower result than HIFU grade group 2, which was very interesting, probability related to the relatively high level, 25% of positive margin, and 50% of those patients had radiation therapy. If we look the detailed result with HIFU, we see that we have only 2% who remain under active surveillance, so that the biopsy showed some cancer but low grade that didn't need any further treatment. We had the possibility to do a second HIFU after several months or 1 or 2 years after treatment in only 5% of cases. And the real salvage treatment, the real failure of the strategy, conservative strategy with HIFU, appeared in 10% of cases. What was the prognostic factor? The risk of failure. Only with HIFU, of course, it was not the age of the patient, it was not the grade group, it was in fact the level of PSA. So we did a post-hoc analysis on this, and we saw that the PSA density was the most important factor. It was not described before. And there were no difference in this risk, either I-1 or I-2, which is very interesting to see that the comportment of I-1 is about the same than the I-2. And when we deal with indication today, it's something we must take into account. We'll see this later. What about the other increased risk? It does not depend on the number of involved sextants, providing there are at maximum 4 sextants invaded. This was an inclusion criteria in the HIFU study. It doesn't depend on the volume treated, either the characteristic unilateral or bilateral disease, except in the situation of bilateral apex involvement, where the risk was a bit superior, about twice the risk of failure, 16%, but still we have 84% success, even with bilateral apex involvement. And there is no significance whatever the combination of involved sextant was. Of course, the functional results, we were very attentive to this, and as expected, the continence and the erectile function were less deteriorated after HIFU compared to radical prostatectomy, as you can detail while reading the whole paper. What about the FARP study? It's very interesting prospective randomized study. This is the first randomized study which compares HIFU and radical prostatectomy. It's a monocentric, done in Oslo, Norway, by my friend Edward Bacco, and the results are here. And its population is very interesting, because you can see that the median PSA is higher than the one in the HIFI study. In the HIFI study, the median PSA in the HIFU arm was 7.1, and here you see it's much higher. It's 8.5. And why? It's because they have 25% I-3 patients. That these patients, I-3, were not included in the HIFI study. And what are the results? They are the same. HIFU is not inferior to radical prostatectomy in this situation. They only had 5.6% radical treatment in the HIFU arm, which is very, very low, and so a very important and interesting study that will be published this year. What are the guidelines today in 2026? They are about the same between the AAU and the EAU. They concentrate on intermediate risk. But if we look at the AAU risk group classification, we see that in intermediate risk, we may have some grade 1, depending on the level of PSA and the situation of the digital rectal examination. We also may have some unilateral grade 3 patients. So these are the best way to select our patient for our HIFU indications. So we probably have to discuss now a new algorithm with those situations of grade 1, 2, and 3. The frequency of the situation is represented here by the thickness of the arrow, and we see that HIFU should be the first line treatment after, in case of failure of active surveillance, but also in many cases of grade 2 disease, and in some cases with grade 3 disease. And of course, it's a first-line indication after failure of radiation therapy. This is well recognized, providing that the patient is presented sufficiently early by the radiotherapist to the urologist with a PSA level less than 4, which is very important for in this situation. And if this is the case, we will have 80% positive response using HIFU as a salvage treatment after radiation therapy. So what are the take-home message? HIFU is there to stay, and it's still improving with the improvement mainly of the image that we get and we put inside the device. The patient selection is crucial, and information of the patient that we will have to follow him a long time after treatment, because of course we have left some untreated part of the prostate, and some cancer could appear, but with no risk, because we follow the patient with generally 2 PSA per year and 1 MRI every 2 or 3 years, and it's enough to be able to diagnose a new localization of the cancer. We have to, in the OR, a rigorous organization and operative technique, as I told you, and we showed that in these situations, HIFU was not inferior to radical prostatectomy, providing we have a long follow-up on a long-term basis. The last word I would say, before I thank you for your attention, is that the focal one itself will be there in this meeting tomorrow morning, and I'll be there for some demonstration and answer any question you could ask. Thank you very much for being here with you today and for your attention.
Thank you, Professor Rischmann. Thank you for your great.
Could I ask one question? Hello? Yeah.
Yes?
Could I ask one question? So, nice presentation, Doctor. So, just wanted to ask, is MRI mandatory before doing a HIFU in a patient? So, how do you mark the areas for HIFU? Is it a MR transfusion sort of a thing? How do you do that?
Yes. Well, first, MRI is mandatory in France for biopsy, before biopsy. So it is done because we do guided biopsy, select on selection lesion what we see, guided biopsy, and randomized biopsy. We have both of it in order to evaluate the stratification of the disease. Then, as you said, we load the images of MRI into the device, into the focal one device, and before we load it, we have work on it and delineate the region of interest, adding also the oncologic margin. That's why on the image in yellow, it was much bigger than the real region that we had on the biopsy. Did I answer your question?
Yeah, sure.
Okay, now we can work during the fusion.
So if there's a patient who is not compatible because of a pacemaker, so with the MRI, so that patient we cannot think about doing a HIFU.
Yes, you can, because you also have about 80% of significant lesion. You can see it on ultrasound, B mode ultrasound first. Second, you can introduce the results of positive biopsy and use it for so you can define the region of interest and use the fusion with this, and it will appear in the left screen of treatment, no problem. Sorry, I have no...
Hello?
Yes.
Are you using... earlier they were showing that there's something like a urethral cooling that they're using.
Yes.
Are you using that also in your system?
Yes, you have a system, a liquid system, and like a fridge in the device, and the liquid is 4 degrees Celsius. And then it goes around, and it's a very specific liquid that doesn't disturb the diffusion of ultrasound and doesn't disturb the image. But while you treat, you have a permanent cooling of the rectal wall. Inside is 4 degrees, outside is 80 degrees, and in between, as you saw on the screen, it's around 14 to 15 degrees. And if it goes up, then the machine will stop.